Hi, this is Lynn, the STEMI coordinator at DePaul, and our monthly EMS education for the month of August is Anterior STEMI. What is an anterior STEMI and how does it affect the patient? We will go over 12 leads, how to read a 12 lead and tell you're having an anterior STEMI, the effects on the patient, what happens in the ED and cath lab. So when we look at our heart from above and we look at the way the EKG, the 12 lead looks at our heart, you can see that whenever you have a blockage under LAD, especially a proximal LAD blockage, you're going to get that ST elevation or those ST changes and those V1 through V4 leads. If that blockage is more mid or distal LAD, you may only see those ST elevation changes in V3 and V4. And then if you have just a blockage in those septal branches that come off of that LAD, then you may only see that ST elevation in V1 and V2. So as you're looking at your 12 lead and looking to see where that ST elevation is, look and see, is that coming, um, do you have that ST elevation in V1 through V4? Then you know that that blockage is kind of more proximal on that LAD. You can also have blockage with your LAD in V5 and V6 if that artery wraps around and feeds that lateral part of your heart a little bit more. Anterior STEMI on a 12 lead. When we're reading an EKG, we want to determine what area of the heart you're looking at, what's being affected. When you look at the charts that I've attached, the 12 lead readings, you can see that these charts kind of give you two different ways to look at it. So when you look at V1 through V4 in a patient that's having an MI, like I said from the previous slide, if you have someone that has a blockage in one of the septal arteries, and only the septal arteries, then you're going to see that ST elevation in 1 and 2. If they have a blockage in that proximal part of their LAD that's also affecting those septal arteries, you're going to see ST elevation in V1, V2, V3, and V4. You can also see some of that ST elevation in some of those lateral leads if that artery is wrapping around and feeding that lateral side of your heart. Whereas some of your other graphs that you look at, they will tell you that V1 through V4 is for your anterior, reading your anterior STEMI. When we look at an anterior STEMI and our heart anatomy, we know that an anterior STEMI will affect that left ventricle or that pumping part of your heart. You can kind of see in the picture here where that LAD would wrap down and what it's feeding there. Think about the electrical pathway of your heart. With an anterior STEMI, you can see the effects on that bundle of His, on both of your bundle branches. You can also see it on that AV node, at times. With an MI, the things that you're going to see are that Mobitz type 2 AV block, the third degree heart block. You could see a left bundle branch block. You could see VFib, VTAC, those idioventricular rhythms, and then you can also see asystole. How does an anterior STEMI affect the patient? The patient that presents with an anterior STEMI is a lot of times they look sicker than a patient that has a posterior or inferior STEMI. Not always. They can have that chest pain, dyspnea, anxiety, nausea. They can be diaphoretic and they can just look ill. The patient that presents with an anterior STEMI has a worse prognosis than a patient with an inferior or posterior MI. The patient with an anterior STEMI is going to be at 50% risk of cardiogenic shock. They are at risk for acute heart failure, VFib, those other arrhythmias that we talked about, cardiogenic shock, and death. You can also see a right bundle branch block in a patient with an anterior MI. Those patients have a more predicted poor prognosis. Other complications that you can see from an anterior MI, you can see that left ventricular dysfunction, left ventricular thrombus, ventricular septal rupture, free wall rupture, pericardial effusion, acute MR, pericarditis. You can see those heart blocks and that left ventricular arrhythmia. When we look at an anterior MI and the causes or how that patient proceeds to cardiogenic shock, we know that an anterior MI occurs when the LAD that feeds the main pumping part of your heart or the left ventricle becomes blocked. This causes the decrease in the oxygen flow to that heart muscle, causing that muscle to weaken, and then that risk of cardiogenic shock to occur. The attached graft can tell you what, as the patient proceeds in cardiogenic shock, what level they are. The patient, the first patient is a patient at risk. The second patient is going to be that patient that you're starting to see the evidence of potential shock, like hypotension, tachycardia, without hyperperfusion. And then the second, that classic cardiogenic shock, you're going to have hypotension, evidence of hyperperfusion that's requiring like volume or some of those vasopressive drugs. As we deteriorate in cardiogenic shock, that patient begins to not respond to those interventions, and you know that they're worsening. You're giving fluids and they're still hypotensive. You have them on Levophed and they're still hypotensive. They're still confused. And then that last stage of cardiogenic shock, that patient has multiple support areas of support for shock. We have them on vasopressors. We have them on an Impella or a balloon pump. Maybe the patient is requiring CPR, intubation, and they're actually looking at placing ECMO. You know that that patient's deteriorating a little bit more. Um, Cardiogenic shock can be described as sustained hypotension that is requiring vasopressive agents. Those patients that have evidence of end organ hypoperfusion, that altered mental status changed, they're cold, they're mottled. Oliguria, they have ischemic liver, kidney injury, their lactic acid is high. They have low cardiac output despite normal filling pressures, and they're just hemodynamically unstable. Some of these things you're not going to so much see in the field, but you can see the evidence of low cardiac output or hemodynamic instability. So you will see some of that in the field. When we treat the patient with an anterior MI and cardiogenic shock, EMS, the first thing you're going to do is identify that patient that's having symptoms of an MI. Obtain vitals and history. You're going to obtain, read, and transmit your 12-lead EKG within 10 minutes of arrival. Activate a code STEMI if you have identified ST elevation in more than 2 contiguous leads, so 2 leads that tell about the same area of the heart. You are going to give aspirin, potentially nitroglycerin to that patient. And then you're always going to use your critical thinking skills to identify that patient who is at risk for cardiogenic shock, or that is maybe going into cardiogenic shock. Is your patient confused? Are they hypotensive? Are they having issues with their rhythm? Do they have signs of hyperperfusion, low blood pressure, mottled, cold, and clammy? EMS will use their EMS protocols to treat this patient as appropriate. Does the patient need oxygen? Do they need fluids because they're progressing and they're hypotensive? Are they requiring things like Levophed or Epi? Has your patient arrested? Are they in respiratory failure now because maybe they're, they're filling up with the fluids, their heart's not able to pump correctly like they should. Some of the things that you're going to see in ED, the ED is going to continue the treatment from EMS. The ED will prepare the patient for cath lab. Uh, they may give heparin or Brilinta. The EMS or ED may have to treat that patient for cardiogenic shock. They'll ask the same things. Is the patient confused? Are they lethargic? Are they having rhythm issues? Are they in respiratory failure? Cardiogenic shock? Have they arrested? They may have to place a central line in the ED, intubate the patient. They may have to place a temporary pacemaker, start things like Levophed or dobutamine or Epi, all those things to help stabilize that patient as they're getting ready to go to the cath lab. Once the patient is in the cath lab, their priority is reperfusion. Reperfuse that cardiac tissue. They're going to do what they need to get a stent in place. The patient may require an impella before we look at the stent or where is that blockage coming from. The case study that I have for our patient with an anterior MI, some of my EMS they've heard this case study already. We have a 66-year-old male who was brought in by EMS. He was stable with EMS. His 12 leads showed an anterior lateral STEMI. This is where I said you may see that, those changes in your anterior and lateral leads with someone that has a blockage in that LAD that's affecting that inferior or that lateral part of your heart. With our EMS, our vitals were 158/98. Our heart rate was 90, respirations were 18, and his oxygen saturation was fine the whole time. When EMS arrived to the ED, the patient quickly deteriorated. His vitals, after a few minutes in the ED, were 55/39. Levophed was started, and then we gave fluids. The patient became very agitated, having respiratory issues and required intubation. And at one point, the patient went into VTAC in the ED and required a shock. Ultrasound was performed to make sure that we still had movement in that left ventricle, and we did have some wall movement, although it was very, very decreased. So in the ED, they did place a central line. We did intubate the patient, like I said, and place the patient on Levophed, and then the patient was taken to the cath lab, where they were suspecting that this patient had an LAD blockage. When we arrived to the cath lab, the first thing we did was placed an impella for this patient because they were in cardiogenic shock. We did a diagnostic cath, which showed us that this patient had a 100% mid-LAD blockage. During our case, the patient went into VTAC over 20 times, and we had to shock the patient. We ended up placing the patient on Epi, amiodarone, Levophed, dobutamine, propofol, and vasopressin. After we placed the stent on this patient, the patient still had an occlusion downstream. The physician felt like that some thrombus had flowed downstream, so we placed the patient on Aggrastat. Ultimately, the patient was in the ICU for 2 days and was not recovering neurologically. And the family decided to place the patient on comfort measures only. So we extubated the patient, and the patient died 2 days later. That's all that we have for our Anterior EMS education this month. I hope you have a great, guys have a great month.